Very special seminar presentation by Bernard Khomenko today. And next week we have another presentation by B-Rad Applegate. And B-Rad will be talking about his photo voice study that relates to the lived experience of unhoused populations here in Missoula and beyond. So stay tuned for that this time next Monday. So I'm going to turn it over to Jim Carinci, and he's going to introduce Bernard.
Hello, everybody. It's good to see you. For those of you who don't know me, I'm Jim Caringi. I'm some of the roles that I play here at the school are as a principal investigator of the Developmental Diversity, Resilience, and Transformation, or DART Lab. I'm also the director of the Intervention Support Corps at CFAR. But the reason why I get to introduce Bernard is because another role I play is a member of his dissertation committee. Dr. Curtis Noonan is his chair and advisor, but is on the road with some sketchy internet for here and there. So he asked that I do this introduction. So Bernard, interestingly, comes to us via Siberia. And he has experience as a high school transfer or as a student visiting student in the Bitterroot, and we were fortunate, I think, over the years to convince him that Montana would be a good place for him to settle. I'll let him say more about that. Bernard's career spans more than 25 years. He's been dedicated to improving healthcare access and affordability, particularly for populations in Montana. He served as a healthcare consultant, a data analytics entrepreneur with his own company, a policy advocate, which all has given him a deep understanding for the systemic barriers that rural communities face in accessing quality care. One of the things that Bernard is interested in is, despite the U.S. spending more on healthcare than any other country, rural states like Montana struggle with provider shortages, healthcare deserts, high costs, and a lack of healthcare infrastructure. So these are the disparities that have really fueled Bernard to getting a doctoral degree in public health, learning to be a researcher. And I will add that having had Bernard in class, that he is the type of doctoral student that you want to have in your class, like the ones that we tend to attract to this program. So Bernard, please take it away, and thank you so much for your presentation today in advance.
Thank you. Well, good afternoon, everybody, and thank you for being here. And Jim, thank you for such a great introduction. So indeed, I'm native to Siberian region of Russia and came to Montana almost 30 years ago. So started as an exchange student in high school and decided to stay, and was very excited to attend the university and get my undergrad, and now a PhD in the process of receiving it. So I'm a second year public health student at the university, and my passion has always been helping people. Whether when I was studying business, and after business school, I went to work in healthcare, so was attracted to nonprofit side of work. And now, of course, seeing a lot of disparities and inequities in our healthcare system, despite us spending so much money, at least twice as much as the closest second, I think it's Switzerland. So our health outcomes are still inferior to most of other countries. So today we'll be exploring about the challenges and opportunities that communities face in their efforts to improve healthcare, and then specifically access to medications. And particularly because we live in a rural state, I'd like to focus with a lens on rural settings. Due to my research work on my thesis, I got a chance to do interviews of pharmacists. So I'd like to talk about that a little bit. And also touch on policies. So what can policies do for us? I think they can be good, not just bad. So, but we also need to learn how to work them. All right, so on the agenda, just very briefly, So we'll start kind of with a big picture. So we'll review what the drug trends are, policies and health outcomes, of course, that are being impacted. We'll talk about the role of pharmacies, pharmacists, pharmacy benefit managers or PBMs, benefit designs. Of course, a lot of us who are on this call were covered under one health benefit or another, so we have to deal with that. Understand, sometimes get confused. We'll talk about the barriers to medication access, specifically some unique barriers that rural population faces. What does it all mean to public health and what are the implications? And probably one of my favorites is to talk some strategies and innovations, so we can discuss, at least begin to understand some ways how the situation could be improved. And of course, some Q&As. So I'd like to answer any questions and definitely welcome questions after the presentation. So the objective is to understand first the national trends in medication adherence, medication cost, anything that's related to medication cost. Now, we won't go too deep into the manufacturing side, but we'll more talk about we as consumers and also the term as payers. So payers could be private payers, could be public programs. What do they face? We'll explore how PBMs, pharmacy benefit managers, and also benefit design influence access and affordability of medications. I'd like to talk about the unique barriers that rural communities face. In my view, the role of pharmacists is so important and is often overlooked. So I'll spend some time talking about the pharmacists and also, again, explore the strategies and how we can improve that equity in drug access. So let's start with the big picture. And we can't talk about the big picture without touching on the drug prices and, of course, the health outcomes. So the medication non-adherence, a few studies that I was able to find, is estimated to cost 100 to 300 billion annually. That's a very, very high number, of course. What's more disturbing is that that particular number comes from the study in 2018. So since then, our healthcare spend, of course, has been growing at high single-digit rate. So, but overall, you can estimate it between 2.8 and 8.3% of the overall healthcare spend is attributed to medication non-adherence. Currently, we hear a lot about the breakthrough therapies, and I think a good example will be GLP-1 drugs. Of course, everybody has heard about them. They came to market probably 5-7 years ago, but really didn't gain the popularity till probably 3-4 years ago. So even for those breakthrough therapies that are currently being prescribed and used for really a series of chronic health conditions, started as a diabetes, weight loss, some hypertension, heart issues, and so on. But we see over 50%, less than 50% adherence at 12 months. So that should be disturbing because if they're very effective, why does this happen? Socioeconomic status, comorbidities, education, and other factors, they also strongly influence the medication compliance. And again, as we live in Montana, a lot of our population is vulnerable. We need to understand what does it mean and what impact that it has. And through the data that I have access to, the studies and the outcomes that I've seen is due to those socioeconomic factors, we see the increase, or if we address them, we can see a reduction to things like avoidable emergency department visits, or even just the overall healthcare spend. I think a telling example of where the policies are going, and again, we'll talk more about the policies. And of course, there's some federal, there's some local. But one of the news that caught my eye is that CMS announced at the end of 2024, ending of what they call value-based insurance design model that was available for Medicare Advantage programs. The program will end in 2025 under the explanation that it was costing too much and was not creating savings that were expected. And of course, at least initially, it's hard to say that that you'll realize savings if you're encouraging people to go get more care. You have to look at those trends as a long-term view rather than the short-term cost. So, but the fact that the program ended, I think, gives us an idea of where the current state of policies are. So a little bit deeper dive on the big picture. So I won't spend too much time, but if we talk about the current drug cost trend. So of course, we're kind of towards the end of 2025, and there are a lot of surveys, a lot of trend analysis that large consulting companies, they release, different industry groups. So for this particular one, I'll just quote a couple. Business Group on Health. It's a organization that represents large employers that provide benefits to their employees. So they surveyed their members, and the members, they expect that the cost in 2026 will increase by 7%. That's by 1 or 2% bigger increase than what was in the prior year. But what caught my eye is that the contributing factor to that increase is largely due to the pharmacy cost increases. So the expectation is that the cost will go up by 12%, and it's actually is unchanged from 2025. So that's a big increase. And what also happens is the employers, when they feel that it's costing them too much, they begin to pass more and more costs to their employees. So and it's either through the premiums, reduction in the benefits, or just increase in some kind of a cost share, so the copay, co-insurance, et cetera. If we talk about what actually is driving the pharmacy trend on the cost side, there are a few stories that emerge. Kind of a good, kind of high-level view on drugs is a specialty versus non-specialty. So specialty are those high-cost medication that require special procedures with handling, et cetera. Some of them are what they call limited distribution drugs. But what you see is that on the non-specialty, it's the inflation, and the inflation is attributed just to kind of this rising cost of drugs that have been in existence, have been offered for a while. There is a little bit of increase in utilization. On the specialty side, most of the increases are driven through increase in utilization. And I guess the utilization, we need to clarify that it's not just the greater number of specialty medications that are being prescribed and consumed. That also happens. But most of it is attributed through what I call as a case mix change, where the lower cost medications are being replaced by higher cost ones. So most of them, of course, are more effective, but their cost can be absolutely astronomical. Some of it well over $1 million. We also need to understand what happens to the member out-of-pocket cost. And as I mentioned, on the non-specialty, where about 90% of those drugs are generics, we see about a flat trend. In fact, some of the reduction. On the brand side, however, there is definitely an increase, and it happens year over year. Perhaps it's a little bit misleading because there are different programs that help to offset those costs. But overall, as a consumer going in and using their whatever that the benefit card that they have, they should expect at least to be asked to pay a higher cost for brands. Another interesting stat is the number of prescriptions over $125 that are required to pay out of pocket. Those medications have seen a 10% increase year over year. So everything is pointing to cost of medications, the ones that are most innovative, is going up, and consumers are facing those, basically being asked to absorb those increasing costs. If we talk more about the drug utilization, I thought a few trends and discoveries would be very telling. So first of them is about vaccines, and I won't touch on vaccines more in this discussion. I'm not an expert specifically on that. I think in our public school, we have some great researchers that study that. But what I've seen is the levels of vaccines in 2024 have dropped to the levels that are lower than even 2019. So, and it applies to both adults and children. So again, it talks about some of the trend changes that we're seeing. Another one is GLP-1. I talked about GLP-1, touched on it at least, that it's innovative therapy, a lot of promise, of course, a lot of hype, but also it costs a lot, not because each therapy costs a lot, per se, relatively speaking, but because so many people could benefit from using it. But we're seeing specifically in the US, and the US again is unique, that the per capita use across counties in the US is not correlated with obesity prevalence specifically. So really what that means is it's not some of the chronic health conditions that are driving the use of GLP-1s. It's other things. So it's the cost, the affordability, access. So I'm sure most of you at least have heard that there was some shortage of that medication, coverage. So all of those things, they influence how people utilize specifically GLP-1, but also it applies to other drugs. Two other stats. One is that if we measure the percent of abandonment, or I guess unfilled drugs for whatever reason, we're seeing that about 27, so 1 out of 4 of the medications go unfilled. And the graph to the right, the bar graph, shows the very strong association between the expected out-of-pocket cost and the level of abandonment. So specifically, this graph shows the new medications, the new prescriptions, but you can see that if the out-of-pocket cost is 0, that abandon rate is 6%. If it's over 250, that abandonment rate within 14 days is over half, so 54%. That's a very significant rise. Well, I think this leads us really to the next topic. So we covered the kind of the high level, big picture, what's happening with drugs, the cost, the utilization. I'd like to talk about what I call the pharmacy drug benefit ecosystem. I'll tell you that it's a very complex system. Jim mentioned that I've been working in the healthcare industry for over 20 years, and it was on the second week I was asked to do a review of the pharmacy benefit manager work. And since that day, I became very passionate about it. So, the more I learn, the more I realize how little I know, and it's a very layered system. But overall, again, it's a complex system. There are a lot of players. There are a lot of flows from the benefit coverage to the dollars and then the premiums to actual physical movement of supplies of the medications. But also, there are a few players, I would say, particularly one that influences, has the greatest impact and influence on this. And I would say in a perfect world, it would probably be prescribing physician, a member, and a pharmacist. So those would be the only 3 players. And by the way, I didn't even include the prescribing physician here. Now, because we don't live in a perfect world, we have a lot of other forces that influence this ecosystem. So pharmacy benefit managers, or PBMs, is one of them. PBMs are unique to the United States, at least their influence. And they really emerged as key players in the space, I would say, in the early 2000s. And they are positioning themselves as intermediaries that help members to utilize their insurance card. So much like if you go and use your medical coverage, in fact, a lot of those medical plans, they would have a contract behind the scene with a PBM, but PBMs specifically focus on the pharmacy side. But because of their influence and the way that the system is built, we have this rather, I would call it misaligned system where those incentives are not necessarily working, not always working in the best interest of members or, let's say, employers that might be paying premiums and so on. So on this particular slide, in a light turquoise color, I've highlighted all the areas where PBMs have some stake or influence. In fact, it gets a lot more complicated. But if you look at this as a, let's say, as an processor of claims, as an administrator of benefits, really these entities, they've turned into really this omnipresent business organization that influences every step. So if you talk about the pharmacies, especially mail or specialty pharmacies, many PBMs own those, or at least have a stake in that. Drug manufacturer, nowadays, a lot of those pharmacy benefit managers actually manufacture their own medications. Rebates, so we'll talk a little bit about the rebates, what they are. Pharmacy benefit managers, they have this separate entities, and separate, when I say that, it's they're either Switzerland, they could be in Ireland or some other really cool exotic places that work with manufacturers to negotiate the contracts. I think my favorite is trying to make sense out of all of it. Is, let's say, understanding how the profits, how the cost is moving. Well, I don't know if it's a surprise to anybody, but at any given point in time, a drug would have 9 or more pricing benchmarks. So if you think about it, as the drug moves through the system and it has 9 different price points, trying to understand, coordinate, synchronize, and really try to figure out whether you're paying a fair price, who is perhaps is charging you too much. It's a very complicated thing. I briefly mentioned rebates. If anybody has been reading about pharmacy benefit managers or drug manufacturers, I'm sure you've heard about the rebates. Rebates are essentially is a after the fact rewards or profit sharing that the drug manufacturers provide to PBMs most of the time, and then PBMs, most of those drug manufacturers, they pass to sometimes to even to consumers, sometimes to insurers. But what it does is those drug manufacturers, they begin to compete on who is gonna be on a preferred medication list that PBMs put together, because usually there's more than one drug manufacturer that provides a therapy. So then they begin to offer those rebates. So it's a competition of who's going to pay more in those rebates off of inflated, let's call them rec rates. So high price initially, behind the scene, the rebates get shared, and that's how the whole system get distorted. So, and that's a very, very high level of this complex, as I call them, pharmacy drug benefit ecosystem. So the role of pharmacy benefit managers. So as I mentioned, they influence drug access and affordability. So they control formularies, and formularies is a list of medications that are preferred. And they usually have at least 2 or 3 formularies. Some of them have more. And they can be designed to the lowest cost, highest rebate, really whatever flavor that you want. Some of them even include generics only. They also control pharmacy contracts, because when you go to fill the script, the money flows through the PBM, so they reimburse the pharmacy contracts. They develop networks. There has been a practice of what I call copay accumulators. If somebody hasn't heard of that term, it's when you receive direct-to-consumer assistance, let's say help you to pay for your out-of-pocket costs, copays. So PBMs jumped on that and said, well, actually run those through us. We'll help you, you being whether it's a patient or let's say an employer, but also take a cut of it. So, but also what happens to consumers is receiving those assistance from, let's say, manufacturers, it doesn't get counted towards the out-of-pocket costs. And that's the downside of getting involved with the pharmacy benefit managers on a copay accumulators. There's also what the term is channel integration. So large chain PBMs, they own pharmacies. I think I mentioned that. Really, what it does is that pharmacists themselves, that people that are at the counter that help to create the medications, they consult the patients, of course, they get kind of squeezed almost to the very end of that chain. So, and the pharmacists that actually can, at least in Montana, make the most impact, they're the rural ones. So that work in rural community, they get squeezed the most. So what happens also is that as benefit designs get offered, there is what I call traditional benefit design. Again, if anybody used their insurance, they probably know you have a copay insurance, out-of-pocket costs. That's not necessarily based on the value of the services. There are some programs, and again, was very sad to hear that Medicare ended their value-based insurance design, but there are examples of the value base where essentially you pay for value. So if the drug provides high efficacy, if it's safe, if it's price reasonable, then you should be able to access it at a discounted price. So those benefits, they don't always get put at the front, again, because we a lot of times value more short-term savings over long-term gains. So rural barriers, especially in um, in Montana. So this is very applicable to Montana. So first of course, is our geographic, I call them structural benefits. So long travel distances. There's a term that has been coined, pharmacy deserts, and we have a few of them in Montana. There is a systematic, again, I talked briefly about the network restrictions where some pharmacies can be excluded from being in network. The benefit designs might drive medications that perhaps that's what the pharmacists rely on to make the ends meet to some other channels like the mail order. There's also cultural factors. So mistrust of this centralized healthcare system. I have another slide on this, but it plays a big role. There has been actually great research that was done at our university that talked about it. So we have to be we have to account for the cultural aspect. So all of that leads that the rural residents the abandonment rates. So the number of non-adherence to the medications is quite high, so 22% in rural residents. I've worked on doing interviews of local pharmacists in our state. So just a few quotes. So one of them I thought is very telling. So this particular interview mentioned that in some of our frontier towns, patients drive over an hour just to reach the nearest pharmacy. And then if that pharmacy closes, and it happened, and we talked during the interview, then what that means is that those patients, they have to drive 3 or 4 or even longer hours. So it makes it very difficult for them to access the medications. So from the practical point, it means that those patients have to go without the medication at all. Of course, as we talk about the vulnerable population, we must at least mention American Indians. So specifically Montana. Another interviewee talked to me about the Indian health services, their impact. And honestly, I walked out from that discussion completely confused and overwhelmed because I thought I know all about insurance, but I realized that I know so little about exactly how American Indians get their health services, how it gets paid for. The fact that the life expectancy is 16 to 19 years lower than white Montanans is a telling fact that we need to address that. And again, the medication access barriers, like patient often delay or forego therapies altogether. And it could be either due to high cost, limited insurance literacy, or just other systematic barriers. Again, I thought if I couldn't tell exactly how the system works, who pays first, where you need to go first or second if you get the denial, I think just regular consumers, regular patients would be confused and definitely impacted by that. So in summary, rural patients they disproportionately face structural and interpersonal barriers to adherence. So there is a lack of trust. And I would say the system that we have, there's probably, unless you work in it, it's really hard to understand how it came to be, how it operates. So I completely understand that lack of trust in the current system. I think failure to integrate pharmacists and to understand their perspective, that's also is very important. We tend to ignore the rural context of, again, this wider disparities in chronic disease management. And in rural population, as they experience those inequities, that leads to worse chronic disease outcomes. So kind of the next big part of my presentation of the seminar is that I want to touch a little bit on the strategies and innovation. So what can be done about this? So first, I'll touch on the policies. So recently, of course, we hear a lot of buzz about reforming PBMs, doing something to bring the cost down, improve the affordability. Unfortunately, it hasn't led to much of the results. So, but nevertheless, I think it's, again, it's such a complex system, and the system of this counterbalances, if you try to do something that's innovative, that is attempting to bring the cost down, make something more affordable, again, like essentially going against the system will fight back. So I think some of the tools that we have, so IRA, so the Inflation Reduction Act, if I remember correctly. There's some price negotiation mechanisms that are built in. So the health plans can piggyback off that. There's also the Section 804, I think became very politically charged. Some states are starting to use it to essentially import drugs from abroad, I think specifically from Canada. There are, of course, some rules, Medicaid waiver, reimbursement protection for rural pharmacies. Montana has passed this amazing law called House Bill 740 that will improve the reimbursement to rural pharmacies. Now, that might sound counterintuitive. Why would we pay more and expect better outcome? Well, because we're paying more for access. And also, when we pay more, again, this notion of a case mix, we might be paying actually for lower price therapies than if we send the patient somewhere to, let's say, a chain pharmacy or to a mail order. I know it's confusing, it's counterintuitive, but that's how it works. Employer-based approach. So employers, they provide majority, or they cover majority of the population with benefits. So employers are also faced with very similar challenges as what the public programs. So they're trying to expand what they call near-site or on-site health clinics, pharmacies. So working with those employers, partnering, so see if those could be made available to other populations as well. Adopting value-based benefit design, so like a low cap on insulin copay. There has been a wonderful program in Montana, actually was pioneered and kind of brought to life out of the University of Montana. It had a very unique benefit design. It went from A to F. You get essentially every drug gets scored almost like a scorecard. It was based on the clinical value of those medications. So worked wonderful for a number of years. There are also community-based strategies, like broaden pharmacy role in prescribing and condition care. There has been some movement, of course, in the last few years on the legislative side. Leveraging pharmacies' trusted status. Again, I wanted to say that a lot of times the pharmacists might be the only provider that's available. On the right-hand side, I have a few stats, again, from the interviews that I've done that counts the words. That's one of the approaches for qualitative methods in the research of what are the barriers to medication, to accessing, that the pharmacies had mentioned. And at the very top, it's a cost insurance program solution. It's only till place 3 that pharmacists mention anything about medications or conditions. So essentially, you see what's on the minds of those pharmacists. So one of the examples is reevaluating the role of pharmacists. So again, just to mention that just a little bit more in depth. So the benefits. Most accessible, provided in rural communities. So often they're the first and only point of care, just because of where they are, where those rural communities are. They have usually a trusted relationship with local community. They know those people. In my interviews, pharmacists mentioned numerous times that they know their patients, they know their needs, and then they work with them either through phone calls or adjusting their hours, or even how the medications are dispensed. They also have proven capacity. So they're trained, they're effective in improving adherence, delivering immunization, managing uh, chronic diseases. So a lot of those roles are not necessarily, we're not asking them to deliver that. I think that's a mistake. So the solution could be utilizing pharmacists' expanded authorities. So there's a limited prescribing. There was a Montana law. Pharmacists, of course, can do the vaccinations. Ensure the reimbursement is fair to independent pharmacies. Again, the Montana House Bill 740 is supposed to assure that. That was a great piece of legislation that was passed. Integrating pharmacy into value-based benefit design and care coordination. So again, steer patients to where they can get the most clinical value, not necessarily where your PBM is telling you to send those scripts. And also use the pharmacist insight. Just ask them a question. What do they see that the needs of the populations are? Again, just another quote from a pharmacist that I've interviewed. We are the ones patients call after leaving the doctor. When cost coverage or confusion stands in the way, they turn to us. I thought that was a just very insightful quote. Another strategy could be public-private partnership. So kind of why does it matter, let's say, for public programs? Well, first of all, is about 60% of non-elderly population in the US to receive coverage through their employer-sponsored health plans. And of course, it comes in many forms. So it could be from the insurance point of view, fully insured, self-funded, could be some other arrangement, just like a health reimbursement arrangement. But the point is that employers have a skin in that, and then they subsidize, they give some money for people to obtain health benefits. In Montana, that actual number is lower. So I think, overall, we know that our employers tend to be smaller than what the national, and the national, the larger employers, they usually have more resources. So, but if employers stop offering those health coverage, those health benefits, then the residents, they would turn to public programs. So, which of course can overwhelm them. So it is important to hear, to listen to what those private, I call them private, but of course it could be state government, counties, et cetera. So essentially anything that's employer-based. That's just kind of how our system works in the US. It's very unique, of course, but what their needs are. So, and if we can support them, then they can support us. So from the private or employer point of view, why would they work with public entities? Private companies, they cannot change the trend, they cannot reduce the cost, they cannot improve healthcare to their employees a lot of times on their own. So they need to have allies, they need to work with other forces. And as we know, healthcare a lot of times is very local, especially in rural communities. So it's only through the partnership that those efforts can lead to some results. So again, because we talked about the pharmacy, I wanted just to bring one of the examples. I have access to several sources of data. So one of the ways that I look at the data is what leads to improvement in a care outcomes, whether it's adherence or the cost. So, and what I found is that it's very interesting correlation that if your pharmacy plan is running well, and here I guess it was mostly on a cost base. And before you criticize me, I want to define that the cost was based on a gross cost. So it's not just, let's say, an employer or a plan cost where you can say, well, you can really reduce the cost by shifting everything to patients. No, this was patient, basically an employee or a dependent plus the employer. So that's how the cost was defined. So a well-run pharmacy plan has a strong correlation. So strong PPV and sensitivity to well-run overall plan. It's not the case if the pharmacy plan doesn't run so well, which can be an indication of other things that are going on, either on the medical side or maybe on the pharmacy. But if you can take care of your pharmacy plan, again, encourage the longer term view, value-based benefit design, improve the adherence, then you can also fix your overall plan. But again, you cannot do that alone. So employers cannot do it by themselves. I thought I'll throw, because this is very thick and very serious, I first wanted to ask AI, what does AI think of common healthcare metaphors? So we all hear of like zero-sum games that are bad actors. So poor Nicolas Cage, my apologies if there's some fans of that actor. I actually didn't know he was rated so low. I had to go and look up. There's some movies like A Job in Bangkok or something like that. Only has a rating of 8 on Rotten Tomato. I think he's much better in The National Treasures. I think it's at 48. Nevertheless, so if we talk about metaphors, so we can almost say, well, what do socks, balloons, and bad actors have in common? There's a term, site of care, and then again, somewhat unique to the United States, but different settings don't get reimbursed the same way. So depending on where you go, the same procedure can be costing you and let's say your insurance plan by multiple factors, different costs, so different amounts of money essentially. So if you go to outpatient to a hospital to get your MRI versus you going to a freestanding MRI center, your cost will probably be much lower at the MRI center. So that's just one of the examples. Another one is in food is edible. I believe we are what we eat. So I always find it somewhat ironic, I think, that the medications that are in a way reversing the effect of the bad food that we consume is actually costing more than food, let's say per month, in many instances. I gotta throw that cap of with the label says PBM, so for the drugs, and I try to list of all the strategies that PBMs say that they use to control the cost. Well, I guess the proof is that the cost of the medication really haven't been going down. So a lot of those things like the network design, gag clause, where the pharmacist cannot talk to you about lower cost alternative, spread pricing, rebates, limited distribution drugs, et cetera, they really don't work. So I call it RX extortion. Bad actors, we talked about it. I think even good actors sometimes can be bad. Has been a discussion about what I call as a most favored nation. I think that's the term. That's not what I call. That's what the term. So drug pricing trade-off. In fact, I was so excited about a year ago to hear one of the CEOs of the big pharmaceutical that talked about admitting that the prices of drugs in the U.S. are too high, and immediately after that, they followed a statement that the drug prices in the rest of the world are too low. So here we go. So I think the rest of the world is looking at us wondering, what does it mean if we get this most favored nation drug pricing? Most likely the prices will go up for the rest of the world. And my favorite one is balloons. So that's kind of a cost shifting is another name, but really everything we talked about here too, again, kind of the system, the way that it's designed, whether it's the hospital, a pharmacy, just the way that it works is that it's almost, you squeeze a balloon by saying, I'm going to try to cut the cost in one area. Most likely it's going to inflate elsewhere. And that's just the way that the system is. So we can still try to be smarter. We can work together, but that's what AI thought about those metaphors that at least I hear a lot. So we've seen how PBMs, rural barriers, inequities create this medication access challenges. We also talked about some potential solutions like policies, working together, working with pharmacists. Those are my thoughts. Again, based on some of the research that I'm starting, still pretty early. um, and also my experience working in the industry. So I want to say thank you for listening and invite any questions that you might have.
Bernard, excellent presentation as usual. Question, as far as, well, I guess I'll stay broad in terms of the strategies of making pharmaceuticals more affordable. I guess I'll use a specific example of, the Good RX or the cards you can get, and you call up, and all of a sudden this $400 a month or worse, way more medication is probably still expensive, but less. If you're it, and a lot of times, right, that's after a pharmaceutical, an insurance company has said, no, 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 the new drug is not available to you because there's this really old drug that's effective and super inexpensive. Who pays for that? Does the pharmaceutical company eat that profit? Do they take it out of their R&D? Are they just being altruistic in helping us? Which one is it? Or I bet it's more complex than any of those things. So
That's a great question, Jim. So thank you for asking it. GoodRx has been a great example of how inefficient the system is, and somebody with the vision can at least attempt to solve the problem of affordability. The discount cards or cash cards, they've existed for a while. I think GoodRx is really taking it kind of to the next level through their efforts to have contracts with pharmacies, and maybe to your surprise or to everybody's surprise, actually with PBMs as well. So my personal story, and I'll just say just two really quick. Through my work, I was helping a company to investigate ways to bring the pharmacy costs down. And it was for a drug, Gleevec, I believe, which is an oral oncology drug that has been available in generic form for a number of years, I would say close to 10 years. And through the insurance that the employer was paying, expecting the value out of that. The cost of the medication for that employer, and actually, so after copay, for employee, but after copays for employer, it was close to 10,000 a month. And I couldn't believe that when I decided, well, I'm gonna call Costco. I'm just gonna call around. Because I saw on GoodRx that the price that was quoted was close to $100. And indeed, the cost of the medication was, for the same medication in generic form, again, actually, that was also generic, which was even more surprising, was $100. So that's I guess is my personal story. There are more, but I won't go into it. But overall, the way that the system works is GoodRx has contracts on the back end, and they use those contracts to run medications through those contracts. GoodRx, of course, takes a cut for their services. The PBM gets a cut for those services. And then the pharmacy, of course, they try to set their price at the level that at least they break even. Some of them, they like to get you into their pharmacy so that you buy something else. But overall, kind of in aggregate, they try to set it at the level that it's economically viable. So the short answer is, when you go with your regular insurance and you pay times, well, like in my example, it was hundreds of times more. What that means is that margin, that difference goes right into the pockets of most likely PBMs on the back end, where they have contracts for the same medication, only different program that they're willing to dispense for less. So
thank you. My phone tells me I have a refill ready, so I'm going to go to the pharmacy and much better informed from your presentation. So thank you.
Jim, you should definitely keep taking your medications. Jim. Yeah. Um, Bernard, thanks for the presentation. Given that value-based programs are sunsetting, at least for CMS, is there still room for there to be value-based programs with respect to pharmacy benefits?
Well, I'm an optimist. I think that Medicare hasn't done a good job evaluating the value of those benefits. Um, I think that it's been probably cut due to not necessarily economic or value reasons, but due to other reasons. But overall, it's indicative of a trend. I believe that employers, so and also I would say local programs. So when I say employers, employer-sponsored health plans, and again, they're public, they're private, like our state, university, counties, etc. They have the ability to design their own health benefits. So their view on benefits is really what matters. And based on the data that I've seen, um, first of all, the out-of-pocket cost for the highest cost medications, they're really small. I mean, they're 2 to 3% of the pharmacy costs. So having a copay or a deductible on those high cost specialty medications, in my mind, makes no sense. They should be available on based on the value of the medication, and there should be no barrier to accessing those medications. So I think it's almost something that it's too maybe unorthodox for the plans to do because a lot of them are underwritten by underwriters, actuaries. That's how they've been taught, and that's how they look at it. I think luckily we have examples again, including in Montana, and current some initiatives where a highest value, and it could be at the also site of care, one of those socks, right? If you go to the right pharmacy, your medications are free. So that could be also part of the value-based benefit design. So even though it's a step back from the federal point of view, I think the private state, I think there's still plenty of information, plenty of room to implement those programs. So I'm optimistic in short.
Hello, Bernard. I'll take a few minutes to ask you a question. Thank you very much. Appreciate your presentation. Uh, I'm a medical anthropologist, and one of the interests I have is like in pharmaceutical practices, especially in like a global environment. And so that's where I'm coming from. Okay. And so I would just say, um, I would be very, and we probably don't have time for this, but I would be, as you move forward, I would invite you to consider when you talk about non-adherence, there's a lot of literature about what adherence and compliance looks like. And so, I'd be very interested to understand more about how you're thinking about that and formulating that as you continue your research, because I think there's a lot of important issues there, in terms of how it's defined and then how people get labeled in terms of they're adhering or complying or not, and what kinds of factors, and you touch on some of those factors, and I appreciate that, cultural, structural, etc., that kind of figure into how one might define and evaluate compliance and or adherence. But I'd be really interested, in how you would kind of explore that more. And then, I mean, sometimes I'm confused about what population you're talking about. You're talking about a rural population, but I would understand that, and then you kind of talk about American Indians, natives, indigenous folks, and I appreciate that. But I understand, or I guess I would expect that there are a lot more differentiations to make within this sort of like monolith of rural population that would play out in terms of gender, in terms of income, in terms of a lot of other factors, diagnoses, what are they being treated for, what drugs come with those diagnoses and treatments and things like that, and how all that might play out. And so I would encourage you to kind of look at those questions. Um, at any rate, I just appreciate you thinking about those questions.
Thank you, Gilbert. I quite honestly, a lot of those points that you brought up, they, they're circulating, bouncing in my mind too. It's such a big field, and in a way, trying to think of maybe those core things that can start improving, at least moving us in the right direction. But what you mentioned, absolutely, we have to be sensitive to just different populations that we have, and the rural population is not the same. One of the pharmacists I've interviewed is in Polson, and in Polson you have very broad base, kind of those disparities in the incomes there, and then so the cases that have been quoted are absolutely stunning. And of course, it could be local that lives there, or just somebody who comes there during summer to play. So, but yes, absolutely. Thank you for input.
Bernard, we had one more question in the chat.
Oh, yes.
Do you plan to interview pharmacy patients?
No, I don't plan to interview pharmacy patients. To understand the side of patients, of consumers, I plan to use health claims data to understand the trends and then their utilization. That's based on their conditions, based on their exposure to out-of-pocket costs, their geographies, etc. But not direct interviews of patients. But I like the idea, so don't think it'll be part of this research, but I really like that.
Any more questions for
Thank you,
Bernard?
Tess.
Okay, Bernard, excellent job with your informational seminar. Please help
Thank
me
you.
in thanking Bernard.
Thank
All
you
right,
for
great job,
staying with
Bernard.
me. So have a good day.
All right, you too. Bye-bye.